Sai Ram all. Welcome to our monthly webinar. This evening, we'll be looking at common thyroid disorders. This is a very timely topic for us to cover since last week was International Thyroid Awareness Week. Our speaker for this evening is Dr. Sivappriyan. Dr. Sivappriyan completed his specialist training in London at the Royal Free and University College London hospitals. In 2012, he obtained his MRCP, Diabetes and Endocrinology, and then in 2018, became a Fellow of the Royal College of Physicians, London. Dr. Sivappriyan has been working as a substantive consultant in diabetes and endocrinology at the Maidstone and Tunbridge Wells Hospital since 2014. He also works at the Leica Health Kim's Hospital and the Spire Alexandra Hospital. Moreover, he is a senior lecturer at the King's College London, involved with medical students teaching. Dr. Sivappriyan treats all aspects of diabetes and endocrinology and has a special interest in thyroid and pituitary gland disorders and complex diabetes. Aside from practicing as a consultant, Dr. Sivappriyan is involved in junior doctors' education and is a speaker at the national and international level. Dr. Sivappriyan is heavily involved in multiple research activities within his field and has published in national and international journals. Dr. Sivappriyan's family attends the Sathya Sai Center of Manor Park in Region 3. If you have any questions during the session, please write these in the chat box and we'll endeavor to answer them at the end of the session. I will now hand over to Dr. Sivappriyan.
Good evening. Myself is Dr. Sivappriyan, and many thanks for giving me the opportunity to come and talk about thyroid problems. During my talk today, I will be going through the common thyroid problems, in particular focus on overactive thyroid problem, which is also called hyperthyroidism. I will also go through in detail about underactive thyroid problem, which is in medical term called as hypothyroidism. I will briefly talk about various thyroid pathways, and I will go through the prevalence of thyroid problems in UK and in the world. I will also explain how people present with various symptoms and signs with the thyroid problems, and I will also talk about why do people get thyroid problems. We will briefly talk about what tests are available for us to find out whether patients have any thyroid problem. And I will talk about the management strategies, in particular about various medical treatment available. I will also go through some special scenarios like during the pregnancy, if you have thyroid problem, how to manage. At the end of the talk, and I will have the opportunity to answer any questions if you still have time left. Thyroid problem has been described by Hindus long time before. In 300 BC, the Hindu holy text discuss thyroid problems in detail. They described goiter as galaganda. They describe people who have had overactive thyroid problem as vatacha, and they describe people who have had underactive thyroid problem as kapacha. So we need to be proud that we have known this thyroid problem long time before. Now we will talk about how a thyroid gland will look like. Thyroid gland is situated in the neck. They are butterfly shaped and they sit in front of the neck, in front of the windpipe, and you can see that on the cartoon here. Thyroid gland produce two hormones and they are essential for life. The first hormone is called thyroxine and we call it T4. And the second hormone is called triiodothyronine and we call it T3. And as I mentioned, they are essential for life, means if you don't have them, you can't live. And they are relatively common hormonal problems we encounter as endocrinologists. Now I will talk in detail about how thyroid hormones are produced. We have a part of the brain called hypothalamus. They will first send signals to master endocrine gland, master hormonal gland called pituitary gland. And the pituitary gland will send further messages and signals to the thyroid gland, and they are called thyroid stimulating hormone. And then thyroid gland, with the help of the iodine, will produce thyroid hormones. And the thyroid hormones will work in different parts of the body. These include any tissues including muscle, bone, kidneys, liver, and heart. And they also send further signals back to the brain to keep a control on the amount of the thyroid hormone being produced within the body. And as you can see, thyroid production is related at various different levels, including the brain, neck, and at tissue level. Now I will talk about the prevalence of a thyroid problem in UK and all over the world. Roughly about 2% of the people in the world have underactive thyroid problem, hypothyroidism. And 1 in 50 women have a risk of developing overactive thyroid problems. And thyroxine tablet and thyroxine medication is the third most common drug prescribed all over the world. And you can see on the diagram here, in the world map here, the red dark dots are the areas where we have highest prevalence of thyroid problems. And most of you, I think, originally come from Southeast Asia, so you have come from a highest prevalent thyroid area. UK also relatively have higher prevalence of thyroid problems in the world. The ladies are more common to get thyroid problem than men, and their risk is about 5 to 8 times. And people will develop a 1 in 8 chance of getting a thyroid problem in their lifetime. And most of the time, if they develop thyroid problem, they are lifelong conditions and they will end up needing treatment often lifelong. This is another prevalent study showing a slightly higher rate of thyroid disease in general population, up to about 6.6%. It even further break down different levels of thyroid problem, which we will talk later, including hypothyroidism, which is the underactive thyroid problem, and subclinical hypothyroidism, which I can call as borderline hypothyroidism, and in postpartum thyroiditis, which is the inflammatory condition that happen after the delivery of the baby. Also, one more point I would like to highlight here is that if you have thyroid problem, diabetes also can be associated, and also if you have diabetes, the thyroid problem can also be associated, and there is a lot of studies to confirm and explain the thyroid and diabetes go hand in hand at times. This is another slide explaining the prevalence of thyroid problems can vary depending on whether you live in the coastal areas where the iodine content is relatively high, or inland areas where the iodine concentration may be a bit low, but also other factors like urbanization and civilization may well play a part, including the formation of certain thyroid antibodies, which we will discuss later. In this slide, we will talk about how patients are present to the doctors with the thyroid problems. They may notice a small swelling in their neck and or in the sides of the neck where the lymph glands are swollen. They may well have difficulty in swallowing. They may well have breathing problems. They may well have persistent cough. They can also present with the direct symptoms related to overactive thyroid problems, which is hyperthyroidism. They can also present with the direct symptoms related to hypothyroidism. They may well also have problems with controlling their long-term conditions like diabetes or cholesterol, or they may well have period problems. And how do doctors find out and confirm whether patients have thyroid problems? They will do blood test for thyroid. They can also check thyroid antibodies. And when they do the blood test for thyroid problems, if they have overactive thyroid problem, for example, like hyperthyroidism, their actual thyroid hormone levels will be high. And their TSH, which is the signal I mentioned earlier, will be on the lower side. When they have underactive thyroid problem, their actual thyroid hormone levels will be low and their signals will be high because they need more signals to produce more hormones from the thyroid. And if they have got any problems with the pituitary gland, their signals will be low and also their thyroid hormone levels will be low. The doctors can also do scans, and commonly we do ultrasound scan. The ultrasounds can help us to find out the normal thyroid gland, but also help us to see any thyroid nodule. I don't know whether you can see it clearly here. There is a well circumscribed thyroid nodule here on this ultrasound scan picture. They can also find out the relationship between the structures near the thyroid gland to see whether there has been any effect on other structures next to the thyroid gland. Now we will talk about hypothyroidism, which is underactive thyroid problems. The prevalence in UK is about 1 to 4%. It affects mainly women, and women are 10 times more likely to get hypothyroidism than men. 95% of the time, the problem is mainly related to the thyroid gland. Only 5% of the time, they can be related to pituitary or hypothalamus problems. Up to about 10% of the cases can be borderline, and we call it subclinical cases, and it may take a while for them to be detected as having thyroid problems. In simple terms, hypothyroidism means the thyroid hormones that is being produced from the thyroid gland is not enough to keep the normal day-to-day function of the body. And it is treatable, and it is actually curable in some people. We will talk in detail about hypothyroidism and the symptoms related to the hypothyroidism. I can confirm with you the thyroid problem can affect any part of the body. In particular, if people have hypothyroidism, they present with general symptoms. They may well have tiredness, they may well have lethargy. When you look at them, they will have puffy face. They may well have a goiter, which is the enlarged thyroid gland. They may gain weight with no explanation for that. They can have period problems, even sometimes fertility problems. They can also have memory problems. Brain fog is one of the commonest symptoms described by patients. And as you can see, they are non-specific at times, and it may take a while for people to understand their symptoms may be related to thyroid problems. Now we will talk about why people get hypothyroidism. The two commonest causes of hypothyroidism in the world is iodine deficiency and autoimmune disease. In a Western world, the commonest cause is autoimmune disease, and in developing countries, the commonest cause is iodine deficiency. They can also be caused by any surgery related to thyroid, or they can be also caused by some other medications that can interfere with the metabolism of thyroid hormones like amiodarone, which is a drug used in certain heart conditions. They can also be caused by some cancer drugs, especially the relatively new cancer drugs like immunotherapy. They can also be caused by a certain viral infection, including the COVID infection, which we will talk later. Some people may be born with no thyroid gland, and it can be related to the poor development of thyroid gland during the fetal period, during the time, the baby development in the abdomen. And they can also be caused by any head injury or any kind of hypothalamic or pituitary damage. There are some patients can also get thyroid problems related to various problems in the action of the thyroid hormone called thyroid hormone resistance, and they often run in the families. If anybody is suspected as having thyroid problems, especially hypothyroidism, this can be further confirmed by a simple blood test. It's a fairly cheap and easy blood test to do, and your doctor will be able to do that for you. And the blood test will show low levels of thyroid hormones with high levels of TSH. And if you have borderline thyroid problem, your TSH levels will be high, but your actual thyroid hormone levels will be normal. And if you have any problems with your pituitary gland or hypothalamus causing thyroid problems, both your TSH levels and your thyroid hormone levels will be on the lower side. Your doctors also often do another blood test called thyroid antibody blood test, and they do a specific antibody for TPO antibodies, and they can be positive in most of the people with the autoimmune thyroid problems. Certain patients are at high risk of developing hypothyroidism. As I mentioned earlier, women is 10 times more likely to develop thyroid problems. And if you are more than 50 years of age, you are more likely to get thyroid problems. If you had a viral infection, especially the COVID infections, you are more likely to get thyroid problems. If you have any other autoimmune disease like rheumatoid arthritis or celiac disease or type 1 diabetes, you are more likely to get thyroid problems. If you're taking any medications to control your overactive thyroid problem, or even had treatment like radioiodine treatment, you are more likely to get thyroid problems. If you had any surgery in the neck, especially the thyroid surgery, you're more likely to have thyroid problems. And if you had any radiation to your neck, like any radiation for any other cancers in the neck, you're more likely to have thyroid problems. The ladies who have been pregnant recently are also more likely to get thyroid problems. The relevance of this is that if you are in any of these age group, and especially if you have any symptoms, you need to be checked for any thyroid problems. Now we will talk about how to manage hypothyroidism. Management of hypothyroidism is mainly replacing the thyroxine hormone, the naturally produced thyroxine hormone, with the synthetic tablets called levothyroxine. And this is the treatment of choice in the whole world. And the aim would be to restore the normal levels of thyroid hormone levels with a view to eradicate the symptoms related to the hypothyroidism. And we decide the dose depending on the weight, and often we do a calculation of 1.6 micrograms per kilogram. In elderly people, we will start with a lower dose and then titrate the dose slowly because of the possible effects on the heart. We also will check the thyroid function test on a regular basis, often every 6 months time, to keep and maintain a good levels of thyroid hormone levels. But I also need to highlight thyroxine replacement is one of the few actions we need to do in people with hypothyroidism. It is important for people with hypothyroidism to understand that they need to look after themselves. In particular, they need to do regular exercise, have a good balanced diet, and also need to explore the possibilities of reducing stress, and need to explore any work-life balance that is required, because with any autoimmune condition, any stress levels can also worsen the autoimmune conditions, and it is important for them to look after themselves in general. I will also give you some practical tips that you could follow when you are on thyroxine, when you are taking thyroxine. Thyroxine need to be preferably taken on an empty stomach and often in the morning. And if you are planning to have a breakfast, you need to have at least 30 minutes gap between your breakfast. And also you need to avoid having any coffee and any milk related products with the thyroxine. There are certain medications that can interfere with the thyroxine medications, and you can check it with your doctor about it. Some conditions can also interfere with the absorption of thyroxine hormones. It can be conditions like ulcer disease, if you have heartburn, for example, or it can be other diseases like autoimmune disease like celiac disease, or it can be certain food intolerance, especially lactose, because most of the thyroxine preparation actually have lactose with it. And if you had any bowel problems, like any bowel operations in the past, your absorption also will be affected. This is where it is important for you to have a regular blood test done and make sure that you are replaced adequately with your thyroxine hormones. I will also highlight some other myths about hypothyroidism. Often people will think they will be symptomatic if they have thyroid problems, and this is not always true. Some people can be incidentally found to have thyroid problems where they are majorly asymptomatic. Also, don't forget, as some of the symptoms are very general symptoms, there is no guarantee by you replacing thyroxine hormone you expect all the symptoms to improve. And it is often quoted in many studies, up to 1/3 of the people with hypothyroidism don't get rid of their symptoms completely, even after adequately replaced with the thyroxine hormones. People also may well worry about any nodules they get in the thyroid gland, and I can confirm with you that most of the nodules in the thyroid glands are benign and they are not cancerous. Sometimes I do see patients coming to tell me that I want to treat and cure my thyroid problem with diet, and I'm afraid there isn't any specific diet that need to be invented because you have thyroid problems, unless you have any problem with the iodine, which I will talk in the next slide. If you have a family history of thyroid problems, there is a higher chance for you to get thyroid problem, but it's not always certain and guaranteed. So you don't need to always worry about it, but equally if you have symptoms, you need to be checked for thyroid problems. Now we will talk about the iodine supplementation, and it is often asked and discussed. And most of the people living in a Western world, most of the food we have is iodine fortified, and we don't necessarily need to replace it. And the general recommendation often for the adults is not to take any iodine supplements. But even if you take it knowingly, it should be not exceeding 150 micrograms per day. And there are certain population maybe at high risk of developing iodine deficiency, especially pregnant women. But again, it is all depending on what is your diet like, and if you're not sure about it, it's better for you to be asked and checked. And there is some evidence to say that certain areas in UK, for example, are more prevalent in iodine deficiency. And again, I'm not going to talk about that today, as this is not relevant to majority of the audience today. Now we will talk about hyperthyroidism, which is also called overactive thyroid problem. In this condition, the body is producing high levels of thyroid hormones from the thyroid gland. And when the body is producing high levels of thyroid hormone from the thyroid gland, it goes to various parts of the body, including the heart, and tissue level cause many different symptoms. And this is also called thyrotoxicosis. Women is again more likely to get overactive thyroid problem than men, and there are certain group are more likely to get overactive thyroid problem. These include any woman who had a recent childbirth, and anybody who has a family history of thyroid problems, and anyone who actually has any other autoimmune disease like celiac disease or rheumatoid arthritis or any other autoimmune disease, and people who are smokers. Now we will talk about symptoms of overactive thyroid problems. When people get overactive thyroid problems, they can either get general symptoms like feeling tired or lethargic, muscle weakness, but they can also get mental symptoms like irritability, sensitivity and nervousness, and mood swings. They can also have heart symptoms like palpitations and tachycardia, increased heart rate. They can also have period problems. They can have hair loss or nail loss. And they can also have eye symptoms like you see on the picture here, where they can have bulging eyelids and bulging eyeballs. Hyperthyroidism is diagnosed by blood test as hypothyroidism. In the blood test, your doctor will be able to confirm whether you have high thyroid hormone levels. And when the thyroid hormone levels are high, the signals that come from the brain, which is the TSH we talked before, will be on the lower side. And the doctors may also arrange special scans, especially the ultrasound scan, and also some nuclear medicine scan called radioiodine uptake scan. And they can confirm or rule out overactive thyroid problems. Now we will talk about how to manage hyperthyroidism. Once a hyperthyroidism is confirmed with the blood test, your doctor will talk about using two different strategies to control the overactive thyroid problem. The first one is to control the symptoms. And we use a tablet called beta blockers, and the actual tablet name is propranolol. The second tablet, which is the anti-thyroid medications, is to control the active inflammation and production of the thyroid hormones within the thyroid gland. They are called anti-thyroid medications, and the actual name is carbimazole. If the medications don't work, or if there is any reason you had allergies to medications or can't take the medications, then we will consider the second line treatment, which can be radioactive iodine treatment. And in this treatment, your doctor will ask you to take an iodine tablet, and the iodine tablet will slowly damage your thyroid gland. And often people will end up taking thyroxine supplements after that. And if there is any reasons you can't take the anti-thyroid medications or radioactive iodine treatment, or if you have a big goiter, or if your choice is to go for surgery, or if there is any other reason we need to control your thyroid within a short period of time, we will consider surgery. Now I will go to some special scenarios, and we will start with a pregnancy. Pregnancy is a state where the thyroxine requirement goes up. And if you are already known to have underactive thyroid problem, hypothyroidism for example, you need to be aware that you need to have a blood test done before you actually go ahead with your pregnancy plan. It is very important in the first 3 months of your pregnancy time, your thyroid levels should be at the top end. The reason being that the baby, the fetus, will not have its own thyroid gland until 3 months after. And during the first 3 months also, your baby will undergo a lot of nerve and brain development, and thyroxine is essential for these brain development. So it is essential for you to make sure that you discuss your plans of your pregnancy with your doctor, and also will have a blood test done before the pregnancy. As soon as you know that you're pregnant, often your thyroxine requirement goes up, and some guidelines recommend you need to increase your thyroxine by 25 micrograms, but it's not a bad idea for you to get an appointment with your doctor for a blood test to have your thyroid levels checked, and then increase the thyroxine dose objectively. We also need to be aware that during the pregnancy, the thyroid hormone levels can go up and down, can also be affected by other hormones within the pregnancy itself. It can be sometimes confusing and may be relevant for you to see some specialist if you have any thyroid problems during the pregnancy. Also, if you have overactive thyroid problem, hyperthyroidism, it is important that your thyroid hormone levels are adequately controlled before you go ahead with the pregnancy. Otherwise, the risk for yourself and also for your baby will be high for various complications, including diabetes, preeclampsia, which is the blood pressure problems during the pregnancy, and it is important for you to recognize this. The second special scenario I will discuss is about COVID infection related thyroid problems. As a specialist, I have seen many patients with thyroid related problems following COVID infections. This can range from overactive thyroid problem, underactive thyroid problem, and more commonly inflammation of the thyroid gland, which is called thyroiditis. Some people can recover from the thyroid problems after the inflammation in the thyroid gland. But what is important is if you are still feeling symptomatic and unwell, it's not a bad idea for you to have a blood test done for thyroid, especially if you had a known positive COVID infection. You will be pleased to know I have come to my final slide, which is a summary slide. So far, I have tried to go through the importance of thyroid hormones in the day-to-day life and how thyroid problems are common and how thyroid problems can overlap with the general symptoms like day-to-day symptoms and often misdiagnosed or diagnosed lately. But one thing to know is thyroid problem can be detected and confirmed and ruled out with a simple blood test. And if you have any question about the thyroid problems, we will try and discuss that during our discussion time. Thank you for your time.
Thank you very much, Dr. Siva, and it's a very comprehensive presentation in simple terms that most people would have understood. And thank you for covering so many aspects in just less than half an hour. Apologies about a little bit of interference during the presentation. I hope that didn't spoil the fun of the listening very much. The first question I wanted to ask you was the thyroid test, mixed edema thyroid, low thyroid, hypothyroid test is done on all the newborns in England. And I think it's been done for well over 50 years. So it must be a very important test. Can you tell us about why it's important and what are the dangers of not being picked up early?
Yeah, thank you for that question. I think it's a very good question. So in fact, it is probably done most of parts of the world actually. And the main benefit has been there has been many much preventable long-term brain development problems. So the relevance of that is actually during the childhood, and I already mentioned about the fetal time, the brain function and brain development is solely dependent on adequate thyroxine supply to the brain. And if children are born with problems with the thyroid, and if they can't produce thyroxine themselves, they will be at risk of developing hypothyroidism and even like brain development, mental retardation. So this particular test you are talking about, I think there are about 3 to start with. Now we got even more. Guthrie test is a heel prick test. Almost all the children born in UK and in many parts of the world, in Sri Lanka I come from as well, they get checked. And if there is any positivity and if there is any problem with the thyroxine levels, it's detected and replaced at that point in time. So equally, if you don't do that, the risk is high. But I think there are a couple of other tests. I think, if the audience know about another condition called phenylketonuria, which is another preventable metabolic disease. So likewise, I think it is very well done, a very simple test, heel prick test, but it's all over the world and it is relevant. Thank you for reminding me on that.
And there was, you covered overactive and underactive thyroid. And sometimes for people listening, it might be a little bit difficult to tell the difference very easily. Can you tell us how common the underactive thyroid is first?
Underactive thyroid disease is probably the commonest thyroid problems, and it's relatively common. I think especially if you come from iodine deficient area and if you live in a western part of the world where the autoimmune disease is high, the underactive thyroid problem is more common. But if you think about the overactive thyroid problem, and if I give you an example, for example, in my clinic, if I see 10 hypothyroid patients, I may end up seeing 1 overactive thyroid problem. So it's the difference, it's 1 in 10 chance less of having overactive thyroid problem. The main difference between the 2 conditions is the underactive thyroid problem, people are often overweight, feels more tired, lethargic, constipated, and even have problems with their mental function. Compared to the overactive thyroid problem, they're a little bit hyperactive. They may well have palpitations, which is increased heart rate or awareness of the heartbeat. They can have sweating and shakes in their hands, tremors, and they may find it difficult to sleep. So that's a kind of a huge difference. But just to confirm, hypothyroidism, which is the underactive thyroid problem, is more common, much more common than overactive thyroid problem. So I think most of the audience, if they have any thyroid problems, I can probably think they will be more likely to have hypothyroidism.
Okay, and the next question to ask was, now in case of underactive thyroid, the onset of symptoms is very, very gradual and sometimes very difficult to pick up for patients and even for the doctors. Have you got some tips about what are the sort of main things that people should be looking for to suspect underactive thyroid?
Yeah, so I think it's a very relevant question. So I think often what happens, as I mentioned during my talk, is that people may simply ignore the symptoms that can be contributed or caused by the underactive thyroid problem. So it could be lethargy, it could be feeling tired, it could be, sleep problems or feeling sleepy, weight gain. So they may attribute that to the day-to-day part of being stressed at work, or even, eating a lot, that kind of thing. So compared to the other non-thyroid causes of those symptoms, often hypothyroidism symptoms are more progressive, so they will only get worse. But your point about people gradually develop hypothyroidism symptoms actually changing as we speak, because nowadays we see more acute flare-up of underactive thyroid problems. So most of the cases I see nowadays are quite rapidly developing symptoms, because I think there is probably a better awareness of thyroid conditions now, and the thyroid test is one of the commonest tests being done in UK, where I'm coming from, means that there is a higher chance for the thyroid problems to be picked up. But the discriminating symptoms can be quite challenging, and it's often, difficult to recognize even as a specialist. But test is fairly easy, and even for the NHS price, it costs only about a couple of pounds for the blood test to be done. So I think the threshold to have a test done is much lower, so means that GPs will be happy to do it, and even most of the other doctors will be happy to do it. And it's often one of the commonest tests done even in the hospital as well. When people come into the hospital, it's one of the tests that often get checked in the beginning. So I think it's more kind of a detection, but the symptoms wise, it can be challenging and it can be difficult to discriminate.
Can you explain the test in very simple terms, like T3, T4, and TSH, and how they relate and how the diagnosis is made?
Yeah. So TSH is called thyroid stimulating hormone. So basically it is the signal that comes from the master gland called pituitary gland in the brain. And that signal goes to the thyroid gland and tell the thyroid gland to produce two different hormones. The first hormone is T4, so that's called levothyroxine, or the thyroxine hormone. And the second one is T3, so it's liothyronine. So when you have any problem with hypothyroidism, the levels of T4 and T3 will be low. To compensate that, the brain will try and produce more signals and send more signals to the thyroid gland and tell the thyroid gland to produce more. But because the thyroid gland has already failed, it's not able to increase the production of thyroxine hormone. So the blood test, when you get it, I think the commonest test your doctor will do will be TSH, and your TSH levels will be high if you have hypothyroidism or underactive thyroid problem. And that test itself is more than adequate to confirm whether you have thyroid problem. Sometimes if your doctor is suspecting whether you may well have a pituitary problem, they will also do the T4 and T3. So that's how it is normally done. So when you look at your blood test, and if you see something called TSH in capital letters, that is the test you need to look for. And often, some of the patients I know have access to their blood results through the patient access services, and they can look it up themselves. And the normal range, we expect that to be between 1.5 to 3.0, that kind of number. So, we can look it up ourselves, so the patients can look it up themselves.
Thank you very much. Once you have hypothyroidism, does it ever go away, or does it change, or do we need thyroxine for the rest of our lives?
Most of the time, when people develop hypothyroidism, it is a permanent damage to their thyroid gland, except in some cases, if they have had inflammation in their thyroid gland, and there is a chance for some of the inflammation to recover and restore their thyroid function back to normal. So that is called thyroiditis. So there are certain cases of thyroiditis which doesn't result in complete and permanent damage of the thyroid gland. Those patients may not require thyroxine replacement, but most of the other cases will need thyroxine replacement, and they are lifelong treatment, and the patients wouldn't be able to come off the treatment. This is another reason why I think you may be aware, and some of the audience may be aware, hypothyroidism, and if you're on thyroxine replacement, as is a long-term condition, I think the NHS has recognized the thyroxine tablet should be free, and you will be eligible for NHS exemption card as well. So I think you probably audience will be aware of that, some of them.
That's a very interesting point, because if you start thyroxine, not just thyroid prescription, but all the other prescriptions are free of charge to you as well. So there may be one of the slight advantages of having low thyroid. You use the terms treatable and curable interchangeably for hypothyroidism. Can you explain those two terms and how you use them with the disease?
Yeah, so I think in a way, I think most of the hormones, whether you want to call it curable or treatable, I think they are two different things. So treatable is that if you treat the symptoms and patients get better from the symptoms, and it is true up to about 2/3 of the cases of symptoms where the symptoms are treatable, but they're not curable, because some symptoms, 1/3 of the people wouldn't really get rid of the symptoms if they have hypothyroidism. But what is curable is their hormone levels are replaced, so they will really have adequate physiological functions within the body that helps their muscle, bone, heart, brain to have a normal physiological function. So that's the reason I was trying to use it. I don't think it is a commonly used terminology, but I often describe that to the patient, because the expectation is such that people may think it's like the infection. You take an antibiotic, by the time you finish the course of the antibiotics, you will get rid of the infection. And I'm afraid it doesn't work like that in some hypothyroidism conditions, because some patients are still left with symptoms. Either they may not be completely related to thyroid problem we started with, or whether they are related but still not really adequately controlled and cured with the thyroxine replacement. So that's the reason I was using as treatable and curable.
Again, sticking with the low thyroid problem, how often should patients have their tests done, and then I'll ask you a follow-on question to say, how do they adjust the dosage?
Yeah, so good question again. So in the beginning, as a new diagnosis of hypothyroidism, you will need a repeat blood test in 6 to 8 weeks time, not earlier than that, because thyroxine is a tablet which has a long half-life, and it will take a while for that to be stabilized within the body. So that means you have to wait minimum 6 to 8 weeks time. And at that point in time, if your levels are not, coming down nicely, the expectation is to get the TSH between 1.5 and 2.0. So that's the kind of a number. Then we can increase the thyroxine dose by extra 25 micrograms or extra 25 micrograms every other day, really. So, depending on the dose you started with. But one thing to say is that as a specialist, we do often get patients referred to us after being started on thyroxine, and where they have failed to improve all their symptoms. And the way we look at sometimes in more detail is to do a full thyroid hormonal profile, including the free T4. And our aim normally would be to keep the free T4 thyroxine hormone levels at the upper end of the normal range. So the free thyroxine levels are normally between 12 to 22. So we try to aim to get the free T4 somewhere around 18 or 19, with the TSH being around 1.5 and 2.5. So the point of, if I repeat the same thing again, if you are not really getting rid of all the symptoms after you've been started on thyroxine replacement, you can ask your doctor to help you to do the second blood test, which is the free thyroxine hormone levels, to see where the levels are. And then with that levels, it is possible for you to micro-tune or micro-adjust the doses of thyroxine. Like I said, sometimes I use extra 25 every other day. Sometimes I use extra 25 micrograms for the weekend or 3 days of the week or something like that. And then we can achieve the dose. Can I also remind the audience, thyroxine has a very long half-life, as I mentioned. So that means by you missing a dose one day, you're not going to come to any serious harm, but equally, it is important for you to take the thyroxine on a regular basis. If you miss the doses, some guidelines recommend you can take the extra dose the following day, same dose, without missing them. And there are some times where we actually bring the patients and give thyroxine dose, within a week time as a whole, especially if we think the patients are not taking their thyroxine dose on a regular basis. So it is very important for you to take the thyroxine dose regularly. Otherwise, it will be really difficult for your doctor or specialist to adjust the dose, because they rely on you heavily to decide, the right dose, depending on your compliance or concordance.
You did briefly mention that thyroid has to be taken at a certain time on an empty stomach, etc. I think it might be worth just reiterating that point a little bit, because it does interfere with whatever you eat and other drugs as well. So if you can suggest the best time that people should take the tablet and how they should do it.
Yeah. So generally, it is recommended to be taken first thing in the morning. But if you can't really achieve that, you can take it last thing in the night. But the main important thing is to avoid any food at least half an hour between the thyroxine dose and you eating. That should include your breakfast, cereals, any iron supplements or vitamin supplements you take. And especially also the milk product and the calcium, with the milk can interfere with the absorption of the thyroxine, and any dairy products, cheese or margarine or anything like that. So in essence, I think 30 minutes gap between any food first thing in the morning is probably the ideal way of taking it. Like I said, if you miss the dose, you can take the extra dose, the following day if you know that you have missed the dose.
So it's best to leave the thyroxine dose by the bedside with a little glass of water and take it first thing in the morning, and then don't eat for about 30 minutes.
Good idea. And, like I said, I think, if you keep on forgetting it in the morning, because most of the people may well have busy schedule in the morning, you can take it last thing in the night. But again, after dinner, you need to leave a gap there, at least half an hour.
Okay, thank you very much. Also, can you explain the term autoimmune? Because you mentioned that in passing with diabetes and thyroid. So where does the autoimmune come? And if there are any tests that are worth having just to prove that as well, that would be very helpful.
Yeah, so autoimmune conditions actually are on the rise. So I think as audience here, we need to be aware of this condition, because this is going to be talked a lot in the future as well. And especially with the COVID pandemic we had recently, and technically COVID infection is seems to be one of the autoimmune conditions, and it triggers a lot of autoimmunity. The terminology autoimmune means that your body, that's your self-defense mechanisms, play a part causing inflammation within the body. So that causes collateral damage to your body by reacting to external agents like infection, in COVID infection, for example. But in thyroid circumstances, it's quite interesting. So what is happening there is that we have certain antibodies, like the COVID antibodies. This time we are talking about thyroid antibodies, cause inflammation in the body, and as a reaction to recover from inflammation, our body try to react and produce chemicals that damage the thyroid cells, resulting in lower production of thyroxine hormone. And what is also interesting for the audience to hear, another one, I may want to give an example. I believe you have a talk lined up next week on oncology. My oncology colleagues are nowadays using immune treatment to treat certain cancers. And that itself is another reason why I see a lot of thyroid patients now, because that immune treatment, which is really good for cancer cells and killing cancer cells, unfortunately giving collateral damage to the thyroid gland and causing thyroid problems. And, I have to actually change some of my clinics to look after these immune toxicity related, immune cancer drugs related thyroid problems. So autoimmune means your body is actually damaging your body. Unfortunately, there isn't any direct treatment available to control the autoimmune disease at the moment, especially the thyroid one I'm talking about. The second commonest autoimmune disease I deal with is diabetes, which is a type 1 diabetes, not the type 2, type 1 diabetes. In children, we really don't know why they get the autoimmune attack on the pancreas, which is the part of the body that produces insulin to control the blood glucose. And the pancreas being damaged by the chemicals again released by the patient's body, and then damage the pancreas, resulting in insulin deficiency, leading to type 1 diabetes. So as a hormone specialist, we deal with, hypothyroidism. I mentioned diabetes, but if I go further, the other commonest autoimmune disease that is associated with a thyroid problem is celiac disease. Celiac disease is a gluten intolerance. And if you have any diarrhea related to gluten-rich diet, that's another blood test. It's a simple blood test you can do to confirm whether you carry the antibodies that cause celiac disease. And like I said, I think it's more common to get another autoimmune disease if you have one autoimmune disease like thyroid problems.
Thank you very much. Can I just ask you to just do a little bit of a revisit to pregnant ladies in hypothyroidism? Obviously, you said before getting pregnant, it's worth having a check and making sure. How quickly should they see people, and should they be attending the hospital for specialist care, and how often should they have tests? I believe they probably need more replacement than normal during pregnancy as well. So if you can elaborate on that one, please.
Yeah, thank you. So pregnant women, I think if they are known to have hypothyroidism before, they need to have a blood test done before the pregnancy to make sure that their TSH levels are between 1.5 and 2. So once they reach that level, they can go ahead with their pregnancy plan. And then the next blood test should be technically at the time they get to know they are pregnant. So straight after the diagnosis of positive pregnancy test, they need to have a blood test done for thyroid. And again, if their TSH is between 1.5 and 2, they can continue the same dose of thyroxine. But most of the guidelines suggest maybe they need an increased dose of thyroxine, and they can even increase the dose of thyroxine by 25 micrograms. And often even our general practitioners end up increasing the dose like that. But then after that, normally the recommendation is to monitor the thyroid function test every 2 to 3 months during the pregnancy. And then who actually looks after you during the pregnancy, if you have hypothyroidism, depends on where you live. Most of the places, the patients who are pregnant and have thyroid problems will be seen in a joint antenatal and endocrinologist clinic, where you will have an obstetrician and endocrinologist or hormone specialist looking after these women and appropriately titrate the thyroxine dose. And then after they deliver the baby, then often they can go back to their normal pre-pregnancy thyroxine dose, especially if they have managed to lose their weight they gained during the pregnancy.
There's no special thing for babies to be checked out or anything like that?
So that's a good question, actually. So I think you will be pleased to know that the chances of the baby need to be screened other than the standard screening for hypothyroidism should be similar, except that they have a long-term risk of developing, hypothyroidism if they have a family history of hypothyroidism. But I don't think we will necessarily need to look for further because mom had hypothyroidism during the pregnancy. It doesn't work like that. Compared to the other problem, which is the thyrotoxicosis or hyperthyroidism. So there is slightly more complicated. This is slightly more complicated issue during the pregnancy. They will need even more frequent monitoring during the pregnancy, like every 6 to 8 weeks time. And often we will need to monitor the growth of the baby during the pregnancy, because sometimes the antibodies I mentioned, which is different antibodies this time, if they have overactive thyroid problem, can cross the placenta and cause growth problems with the baby. So we need to monitor the baby as well carefully. And also sometimes, the children born to the mother who has overactive thyroid problem or hyperthyroidism can get, thyrotoxicosis, overactive thyroid problem as well. So they need to be checked and treated appropriately for that. So slightly more chances of getting more complications during the pregnancy. Unfortunately, even some drugs we use to control the overactive thyroid problem also need to be monitored from the fetus point of view, the baby point of view, because it can also cause problem with the formation of the scalp, the head development in the babies as well. So it's slightly more tricky condition to manage during the pregnancy.
I'm glad you mentioned overactive thyroid, because we've been ignoring the overactive thyroid all throughout our questions. And the question I was going to ask you was, it is not as simple as underactive thyroid. So you treat it with drugs and things and radioactive iodine and whatever, and it can wane between more thyroid and less thyroid and no thyroid. So can you explain that just a little bit?
Yeah, so overactive thyroid problem, fortunately, less common than underactive thyroid problems. And the standard of treatment is actually medical management in UK compared to US. First line treatment often is radioiodine treatment, actually. So what we do in UK is we give medications to control the thyroxine hormone and keep the levels within the normal range. And we try and use the lower dose of the medication to achieve that. And often we will be able to come off the medication after about a year or year and a half time. And there is a 50-50 chance of this condition coming back, overactive thyroid problem coming back. And if they come back again, we normally go for second line treatment like radioiodine treatment and surgery. And you're right, I think at least half of the people may be left with a normal thyroid function test long term. The rest of the half who develop recurrence of overactive thyroid problem may end up needing definitive treatment with radioiodine treatment and surgery, and those result in underactive thyroid problem requiring thyroxine replacement long term after that. But again, these are the conditions. They are curable at one point. It's very important to be treated as well equally, because it can have negative effects on heart, bone, and cause osteoporosis, increased risk of fractures, So I think there are a lot of risk associated with it. And sometimes, even rarely, patients may end up getting admitted to the hospital with overactive thyroid problem because it can be quite dangerous and affect the heart function and cause even heart failure in some people, especially if they have any underlying heart problems.
Thank you very much. And with the underactive thyroid coming back again, are there any associations with cholesterol or heart disease and other things like that?
Good question. So it is very common for us to see cholesterol problem being associated with poorly controlled thyroid problems, especially the hypothyroidism we are talking about. So when we see any patients with high cholesterol and high triglycerides, which is another part of the lipids, we often always look for any thyroid problems. So it is associated definitely, because you need enough thyroxine to clear the cholesterol within the body, for the cholesterol metabolism to work properly. There is some evidence to say if you're not really having enough thyroxine levels, especially if it is very critically low levels, your heart function will be affected, and even to the point of developing fluid around the heart, slowing down the heart rate. And even some people can be admitted with a particular condition called mixed edema, where people can even be confused and drowsy and almost having seizures like activity, and they end up coming to the hospital with emergency admissions, and we'll have to sometimes even put them in intensive care to treat them and replace the thyroxine, and it can be quite challenging. And the death rate in that condition is actually high. I'm glad to say that in UK it is much less common for us to see it, but I have to say that it is still happening in other parts of the world, and they can be quite life-threatening condition if anybody has them.
Thank you very much. You'll be pleased to know I've only got 2 or 3 more questions. Now, this one of them is very technical, and I think this must be a very specialist patient that has asked me this. Can you tell them something about Hashimoto's and Graves' disease?
Yeah, I'm glad this question came. So because I think people need to recognize Hashimoto's thyroiditis is the commonest cause of underactive thyroid problem in UK. So half of my patients who come to see me when they are really tried everything to control their thyroid problem, we need to recognize as they have Hashimoto's thyroiditis, it is a multi-system disease. So technically it can affect any part of the body. The inflammation we mentioned that can happen in the thyroid also can happen in different parts of the body. Often these people complain symptoms of getting intermittent joint swelling, joint pain, body aches, and brain fog. Often sometimes patients write down a long list of symptoms. So it is a multi-system disease. We ourselves with the juniors and all the other team have written many case reports about even some of these patients presenting with fits and some of these patients presenting with, fluid around the heart and everything. So it can be quite challenging. But what is important for you to recognize is that I think as a first step, you need to recognize it's not uncommon for us to see that the other system can be affected. How to improve it? I think stress does play a part in flaring up of the Hashimoto's thyroiditis. So you need to think about following something that helps you to de-stress through your body, whether it's yoga or mindfulness or any of the physical activities that helps you to do that. The second thing is I think there is evidence to support replacing vitamin D levels adequately will help with any autoimmune disease, but in particularly Hashimoto's thyroiditis as well. The other thing maybe thinking about taking some food rich in antioxidants will be very, very helpful. The other terminology you mentioned is Graves' disease. So I think these two names actually come from people and physicians who describe this condition. Hashimoto's is a Japanese physician who described this condition. Graves' disease is a UK one. So basically Graves' disease is an overactive thyroid problem, commonest cause of overactive thyroid problem. Where people get, thyroid problem being overactive, but also can get symptoms in the eyes with the bulging of the eyelids and the bulging of the eyeballs I have shown you before. So that's how it happens. And hopefully that answers that question.
Thank you very much. That was very helpful. And there were 2 little questions that people wanted to ask. One was, is sleeping problem associated with mixed edema or low thyroid? And are there any tips to deal with it without taking sedatives?
Yeah, so I think, normally taking sedatives are discouraged anyway, because it often worsens the sleep cycle rather than, helping them in a way. And you're right to say thyroxine levels need to be adequate and optimized for you to have a good sleep. I did mention earlier that it is somebody who has overactive thyroid problem. They always, one of the symptoms may be poor sleep and they find it difficult to sleep. But equally, hypothyroidism, if it is not adequately replaced, you can have a prolonged, sleep cycle, especially the deep sleep. So the only thing from the thyroid point of view you can do is to optimize the thyroxine levels. But then, sleep itself is an interesting one. And I think, maybe, one of my suggestions may be to find a sleep physicians and come and talk about it, because I do enjoy seeing some of the referrals I send sometimes to sleep physicians. I think, you do have sleep services in East Grinstead, isn't it, locally? I think, you may be aware of that. So where the sleep physicians actually, people ignore about the sleep problems. Especially, people who have had, shift working and, many different things. And people talk about even sleep related health problems, including the risk of diabetes and everything. But back to your question about, how to improve the sleep from the thyroid point of view, I think the only thing you can do is to try and optimize your thyroxine levels. But equally, things like sleep hygiene, and I do find some helpful website which gives advice about, sleep hygiene means that regular sleep, avoid caffeine, and maybe reading a book, and have a dark environment, avoid screen time, that kind of things often can be helpful as well if you have any primary sleep problem otherwise. But if you are not really sure what kind of sleep problem you have, you may need to see a sleep specialist in that regard.
And the last question is, dry, frizzy hair, coarse hair, and dry skin associated with hypothyroidism. When you treat it, does it go away, or do you need to do something?
Most of the time, actually, they improve, I have to say. But we also need to look further whether they could have any other vitamin supplementation problem related to the hair, issues and the musculoskeletal symptoms you're talking about. So what we normally look for when somebody has any hair problem other than thyroid is to look for vitamin D levels problem or vitamin D deficiency. We also look for vitamin B12 and folate deficiency. Zinc is another one we often check. And the other one is iron deficiency. And it's important for you to realize it's not only replacing them, but I think it need to be adequately replaced. The way it works is that if you have vitamin D deficiency, even at a borderline level, it can really have impact on your hair problems or even skin problem. But equally, because all these organs mentioned are very slow growing organs, it takes a while for you to see any improvement. And often we say to our patients that if you had a hair loss related to thyroid problem or any other hormone problem, it can take up to about 6 months before you start seeing any improvement, because the hair follicles, grow very slowly compared to, many other parts of the body. So the problem with the hair will take a while for them to get better, minimum 3 months up to 6 months time. But the top advice would be to look for other causes like vitamin D deficiency, iron deficiency, and perhaps take some zinc supplements, because zinc test is difficult, but taking supplement is easy.
Thank you very much, Dr. Siva. And we have overrun by a couple of minutes. And thank you for all the answers that you've given in such a nice, comprehensive, understandable manner. I would also like to thank the tech team for helping to support and present this nice presentation, and for organizing and the organizing team for arranging this session. The next session is an overview of oncology, which will be on our next month's in our July one. So please do attend that. Thank you all for participating and listening to us and sending in all the questions which made the talk even more interesting. And above all, thank you very much to our dear Swami, without whose grace nothing ever happens. Please tune in for the next session. Sai Ram to all of you.
Sai Ram, thank you for your opportunity.